पहले कार्तिक
Hello, everyone. Hello, am I audible to all of you? We are about to start at 10 sharp. Uh, but before that, I just want to uh, make sure that I'm audible to all of you. Is that so? Hello?
Yes, we can perfectly hear you.
Okay, that's great. So here we start. Good day, good evening, and good morning to everyone joining us from different part of the world. I am Dr. Abdul Hasib, and I'm joining you today from Peshawar, Pakistan. I serve the Operating Room Global Education and Training Committee as a lead faculty urology and endourology. On behalf of the Operating Room Global and the Global Education and Training Committee, I'm delighted to welcome you all to today's global webinar. We are pleased to have a truly multidisciplinary audience with us today, including surgeons, anesthesia providers, nurses, paramedical staff, educators, researchers, student, and healthcare leaders. We are currently joined by participants from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you are joining us from Africa, Europe, Asia, Middle East, or elsewhere, you are very, very welcome. Good morning to those joining early in the day, good afternoon to those in the middle of the day, and good evening to those of us joining later. We are grateful to have you all with us. We strongly encourage active participation throughout the session, so please use the chat box to introduce yourself by sharing your name, your professional title, and a country. Post your question and comments at any time during the presentation. Our moderation team will be actively monitoring the chat and will bring your question forward during the discussion segment. For those joining the Operating Room Global session for the first time, let me introduce the Operating Room Global is a multidisciplinary professional platform that is representing over 260,000 surgical and perioperative professionals across more than 110 countries, making it the largest global network of operating room professionals worldwide. The Operating Room Global brings together 42 healthcare disciplines and specialty currently and operates as a not-for-profit and non-governmental organization founded in Nigeria in August 2015. Today, the Operating Room Global has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and perioperative care through education, research, and advocacy, innovation, and capacity building, with a strong focus on safety, equity, and system strengthening. The Operating Room Global is an internationally accredited continuing professional development provider recognized by the CPD Group, underscoring the quality and global relevance of our educational activities and is supported by its academic and innovation arm, the Operating Room Global Center for Education, Research and Innovation, incorporated in Ireland, which leads our global agenda in education, research, innovation, and partnerships. Our affiliated journal, named the Operating Room Journal, is open access peer-reviewed international journal inaugurated in May 2025, providing a platform for high-quality evidence that informs practice and policy worldwide. The Operating Room Global is also proud to host its own institutional review board officially registered with the U.S. Office for Human Research Protection, reinforcing our commitment to ethical, responsible, and globally credible research. The Operating Room Global is driven by a volunteer-led leadership model powered by passionate professionals who contribute their time, expertise, vision to strengthen global surgical care. We are actively engaged with global alliances, including the G4 Alliance Intersurgeon, and are listed with the Union of International Association and the Global Civil Society database, reflecting our global accountability and reach. So from here, I would like to invite my colleague, Mr. Emmanuel Tayashmir, to take the session from here forward and welcome our guest for today's session. Thank you.
Thank you so much, Dr. Abdul, for the great opening remarks. And thank you everyone for joining on time. My name is Emmanuel and I'm joining you today, this evening from Rwanda. It is my absolute honor to introduce and to welcome you all again to this global webinar to introduce our first guest speaker for today's session. Our first speaker is Dr. Fekrey Gebru, an assistant professor of anesthesiology, critical care and pain medicine at the College of Health Sciences, Mekelle University, Ethiopia. Dr. Berhe currently serves as head of the Department of Anesthesiology, Critical Care and Pain Medicine at Ada Comprehensive Specialized Hospital, one of Ethiopia's leading tertiary health care teaching institutions. He has extensive experience in anesthesia, critical care medicine, perioperative management, and the care of complex surgical and critical ill patients. In addition to his academic and departmental leadership responsibilities, Dr. Berhe previously served as director of the operating theaters at Ada Comprehensive Specialized Hospital for 3 years. In this role, he played a key part in overseeing surgical operations, optimizing theater efficiency, and promoting high standards for patient safety and perioperative care. Dr. Berhe is dedicated to advancing anesthesia practice, critical care medicine, and pain management through clinical excellence, medical education, and healthcare leadership. He continues to contribute significantly to the training of medical students, residents, healthcare professionals, while delivering specialized care to critical ill and high-risk surgical patients. He is also an active member of the operating room group. Today, he will be speaking on perioperative anesthesia management of the critical ill surgical patient. Please join me in inviting Dr. Fekrey Berhe Gebru to deliver his presentation. Thank you.
Okay, am I audible, guys?
Yes, you are audible.
So thank you for the nice introduction, Emmanuel and Dr. Abdu, and I'm happy to be in this session. And hello, everyone from every corner of the world. So I will now share my screen to continue with my presentation. Can you guys see my screen?
Yes,
It's visible?
yes, it's visible.
Okay, okay. So for the sake of time, I will be starting now, and we will continue with the Q question and answer at the end of the presentation. So the topic of our today's presentation is on perioperative anesthesia management of critically ill surgical patients. So I am Dr. Fekrey, as an assistant professor of anesthesiology, critical care, and pain medicine from Haidar Comprehensive Specialized Hospital, Mekelle University in Ethiopia. So those will be our learning objectives: to identify high-risk surgical patients and recognize early signs of physiological deterioration, to apply structure pre-optimization and resuscitation, to select appropriate hemodynamic, airway ventilation, and anesthesia management strategies, to manage special populations like the septic patients, hemorrhagic patients, patients with pulmonary hypertension, obese, and elderly patients, and to implement effective post-operative care monitoring and multidisciplinary handover to the ICU. So this will be the outline of my presentation. So we will have foundation, then preoperative phase, intraoperative management. We'll see special conditions, then supportive care and post-operative and systems management. So coming to see who critically ill surgical patients are. A surgical patient is considered critically ill when they exhibit acute physiologic instability or organ dysfunction that places those patients at greater preparative morbidity and mortality. So the place from where we accept critically ill surgical patients, it could be from emergency department, it could be from the general ward, or it could be from intensive care unit. So usually from the emergency department, we get major trauma patients with uncontrolled hemorrhage or intracranial hypertension requiring urgent decompression before full resuscitation, or from the wards, patients who deteriorate after admission. They might have undergone partial resuscitation, but requiring more precipitous operative intervention. And those from intensive care unit already receiving multi-organ system support, then they might sometimes need surgical intervention. So if we see the patients at high risk of physiological deterioration from the nature of their disease, emergency admissions are at high risk of physiologic deterioration. Elderly patients, patients with pre-existing conditions like diabetes, hypertension, renal failure, and immunosuppression, specific patient groups taking medications, corticosteroids or NSAIDs, particularly severe from the outset if patients have a severe illness from the outset, if they already have developed complication, if there is a failure to progress after initiation of management, if the patient has shock, also patients recovering from anesthesia and massive blood transfusion recipients, those are patients at high risk of physiologic deterioration during the perioperative period. So why surgical patients become acutely ill? It could be from various reasons. One, from the primary surgical condition, like, for example, peritonitis, intra-abdominal sepsis patients, bowel obstruction or uh, bowel ischemia patients, major trauma, hemorrhage, and patients with compartment syndrome. Or it could also be the result of their pre-existing medical diseases like diabetes, heart failure, coronary artery disease, COPD, and chronic kidney disease. Patients might also develop new medical illness inside the hospital, like hospital-acquired pneumonia, pulmonary embolism, acute coronary syndrome, delirium, and electrolyte disturbance. Or the critical nature of their disease might be secondary to surgical complications, for example, like anastomotic leak, postoperative bleeding, surgical site infection, or organ failure. So when we come to the preoperative phase of management of critically ill surgical patients, we have to start from the assessment. So we have to assess the airway and the respiratory reserve of the patient. Like we can see the saturation, the arterial blood gas analysis. Depending on the nature of the patient's presentation, we might also have to order chest X-ray. And we have to also assess cardiovascular status, like volume status, if there is any need for inotrope support and cardiac function. We also should see the neurological status, renal function, coagulation status. If in case of septic patients, we have to make sure that the source is controlled, and we have to also make sure that they are started on appropriate antimicrobials and the timing as well. And when we come to the optimization priority, the first thing, resuscitation. So we have to restore perfusion before induction when time allows us. And we also have to coordinate with surgeons in initiation of early antimicrobes and go right away to control the source of infection. And in the meantime, we have to correct reversible factors like hypoxemia, acidosis, hypothermia, and electrolyte disturbances if time allows us. And the monitor parameters, we can use IBP, invasive blood pressure monitor, with or without central access before induction, depending on the severity of the surgical patient condition. Then we also have to do team briefing, discussing the plan and any contingency plans and ICU bed availability for post-operative time. So coming to the resuscitation goals before induction in the airway, if the patient have no secure airway, we have to secure the airway. We have to reach our target oxygen saturation more than 94% based on the patient's condition. It could be patient specific, and we have to pre-oxygenate before induction of anesthesia, either with high flow nasal cannula or non-invasive ventilation whenever appropriate. And in the circulation, we have to restore adequate perfusion pressure, keeping the mean arterial pressure more than 65 millimeter of mercury. Lactate and urine output also should be monitored. And we have to use fluid management judiciously, and we have to avoid hypo or hypervolemia. And if possible, using the dynamic assessment for fluid responsiveness should be encouraged, and other metabolic derangement should be addressed if time allows us before induction. So coming to airway management in the critically ill, as we all know, rapid frequency intubation remains the cornerstone for emergency airway control in unstable patients. So before the patient comes to our theater, we have to prepare, we have to complete our equipment, check difficult airway plan, suction, rescue devices like supraglottic airway and front of neck access, and an experienced provider should also be around. And we have to pre-oxygenate patients with high flow nasal cannula. We can also do apneic oxygenation during intubation attempts. And as we all know, since most anesthesia IV induction agents are uh, hemodynamically not friendly, as much as possible in those critically ill surgical patients, we have to choose anesthetic agents that have minimal effect on the cardiopulmonary system. So we have to use ketamine or etomidate in case of, specifically in case of shock states, and we have to avoid high dose propofol in case of unstable patients. And in case of neuromuscular blockade, we can use succinylcholine or high dose rocuronium, and we have to ensure the ability to ventilate or rescue before providing paralytic agents. And in order to make our first pass successful, whenever available and situations allow us, video laryngoscopy is recommended as a first line because it limits number of attempts and associated use of higher dose of IV anesthetics for induction. And post-intubation, we have to confirm placement, initiate lung protective ventilation, then we have to keep supporting the hemodynamics immediately. And coming to hemodynamic monitoring strategy, essential, we know the ASA standard monitors. So in addition to the ASA standard monitors, we have to have, if possible, continuous arterial pressure monitoring, invasive blood pressure monitoring, central venous pressure whenever indicated, urine output, fluid balance, serial lactate, and base excess, and point of care ultrasound, like cardiac ultrasound, IVC, and lung ultrasound. And based on the situation that we are facing, we can use advanced hemodynamic monitoring like pulse contour, esophageal Doppler, or PA catheter when patients are entertaining complex shock states. Or we can also central venous oxygen saturation or the venous to arterial gradient of carbon dioxide concentration in the blood because they are markers of oxygen delivery and tissue perfusion. And in selected neurosurgical patients, cerebral oximetry and goal-directed therapy is recommended. Coming to the choice of fluid in critically ill patients, IV fluids are medications, so they should be administered and prescribed wisely. So we have to choose the composition and volume carefully based on the physiology and the disease state. So as we all know, crystalloids are the first line agents for resuscitation. So balanced crystalloid solution like plasma light or lactate ringer. But when we use 0.9% sodium chloride, we have to be careful because excessive administration might result in hyperchloremic metabolic acidosis. And those crystalloids are used for initial resuscitation, and we have to avoid large volumes. And among the colloids, albumin is recommended in selected hypoalbuminemic states, and starches are largely abandoned due to risk of acute kidney injury, and colloids are not routinely recommended for acute resuscitation. So you should also consider cost benefit carefully. And coming to blood products, in case of hemorrhagic states, we have to initiate early balanced transfusion. By early balanced transfusion is to mean keeping the ratio of the blood products 1-1-1, the whole blood or red blood cells with other products of blood like fresh frozen plasma where the clotting factors are there, and the platelets has to be in 1-1 ratio. So usually the target hemoglobin is individualized, but usually ranges from 7 to 9 gram per deciliter for initiation of transfusion. And if there is any coagulopathy, we have to correct it early. Vasopressors and inotropes. Norepinephrine is first line in case of sepsis and most vasodilatory shock. So we have to start it early, and we have to support the mean arterial pressure, minimizing the tachycardia. Vasopressin is an adjunct in catecholamine refractory shock, and epinephrine is the first line in anaphylaxis and low cardiac states, and is also useful as second agent in septic shock. Dobutamine is important for inotropic support when cardiac output is low, but we should be careful because it might cause vasodilation, and we have to monitor closely. Milrinone is recommended in right ventricular failure and in patients with pulmonary hypertension. But at the same time, milrinone is an ionodilator, and in patients with systemic hypotension, we have to be careful. And phenylephrine is a temporary pure vasoconstrictor, so it has limited role. And coming to intraoperative ventilatory strategy, lung protective ventilation reduces postoperative pulmonary complication in high-risk critical ill patients. And the recommended tidal volume is to keep between 6 to 8 ml per kilogram of predicted body weight. And we have to, if we use higher volumes, we might cause polytrauma. HIP is individualized, so usually recommended between 5 to 10 centimeters of water typically, but we might even keep it higher in patients with acute respiratory distress syndrome and obesity. And plateau pressure should be kept less than 30 centimeters of water, with the target driving pressure less than 15. And FiO2, we have to titrate our FiO2 to keep the oxygen saturation between 92 and 96, keeping in mind avoiding hyperoxia. And recruitment, we have to be selective when using recruitment because of the critical nature of those patients. There might be risk of hemodynamic instability with the recruitment strategies. And we can as far as we maintain the minute ventilation, we can use either volume or pressure control mode. And coming to the choice of anesthetic technique, usually general anesthesia is the most common for major emergency surgery, but we can consider regional or combined whenever feasible, like in case of limb surgery. In case of general anesthesia, induction, since those patients are critically ill, we have to use hemodynamic friendly agents like ketamine, etomidate, especially in shock situations. And we can use volatile or TIVA for maintenance, but we should keep in mind to avoid deep anesthesia because of the hemodynamic nature of those critical ill patients. And opioid sparing multimodal analgesia should be promoted. Neuromuscular blockade should be also carefully monitored. We have to maintain normothermia and euvolemia. And the benefits of regional anesthesia, we can reduce opioid requirement, and you can also avoid risk of delirium, but there is risk of, if in patients with coagulopathy or shock, we have to be cautious. We can also use epidural for major abdominal case if the patient's hemodynamic status is stable. But if we are escalating vasopressors, we have to avoid neuraxial anesthesias. So coming to the special situations, the first one is severe sepsis, like septic shock, sepsis with septic shock. Anesthesia management is, we have to keep in mind to provide the things in the first 1 hour, the golden 1 hour of sepsis management. So in the meantime, we have to communicate with the surgical team, and source has to be controlled because that's the definitive and that's the one with significant mortality benefit. And antimicrobial agents, you have to administer appropriate IV antibiotics within 1 hour of recognition of sepsis. And we have to keep reassessing for the response. And resuscitation fluid 30 ml per kilo. If not responsive, we can start norepinephrine as a first line to keep our target map more than 65 millimeter of mercury. And in the meantime, we have to monitor peripheral perfusion using serum lactate. And when patients with septic shock comes to anesthesia, we have to induce them with ketamine preferred, but titrated ketamine. And we have to expect further hypotension. And if patients are already on vasopressors, we have to keep running the vasopressor while inducing patients. And the recommended ventilator strategy is lung protective strategy because ARDS is common in patients with sepsis. So we have to remember to avoid high PEEP if the hemodynamic is unstable. And in septic patients, putting invasive blood pressure monitor and doing serial ABG and serum lactate and other advanced cardiac output monitoring is advised. And the other special patient groups are patients with perioperative hemorrhage and massive transfusion. So in patients with perioperative hemorrhage and massive transfusion, we have to keep in mind to do damage control, meaning prioritizing hemorrhage control over doing the definitive repair, because those patients are highly unstable. We should give priority to controlling the hemorrhage and delaying the definitive surgery after stabilizing the patient. So like mentioned previously, massive transfusion protocol, we have to keep the balance 1:1:1 when administering red blood cells, FFP, and platelets. And in some selected patients, we might also do permissive hypotension in patients with ongoing blood loss, but not in traumatic brain injury. We might keep the systolic blood pressure between 80 and 90 until the hemorrhage is controlled. And in trauma patients, we have to also keep in mind to avoid the fatal triads, the hypothermia, acidosis, and coagulopathy. And if we have, we can keep doing the viscoelastic testing, bedside point of care tests like the TEG and ROTAM should guide us with regard to which blood product to transfuse to patients. And calcium, ionized calcium has to be maintained in the normal range, and early tranexamic acid should be considered in trauma patients. In patients with pulmonary hypertension markedly elevates perioperative morbidity and mortality. It's reported between 7 and 24%. So interdisciplinary planning is essential, and we have to avoid triggers of acute right ventricular failure like hypoxemia, hypercapnia, acidosis, hypothermia, hypervolemia, inadequate anesthesia or analgesia, and high airway pressure. So those things has to be avoided. And intraoperative management priorities has to be in selecting pulmonary vasodilators like inhalational nitrous oxide, iloprost, or inhaled milrinone. And we have to maintain the systemic blood pressure higher than the pulmonary pressure. If the blood pressure is low, we can use inotropes like norepinephrine or vasopressin. We have to optimize right ventricular preload carefully, avoiding overdistension, and we should use invasive hemodynamic monitors to help guide us in keeping those hemodynamic goals. The other special patient group is the elderly, and elderly at the same time critically ill. So in elderly critically ill surgical patients, the overall ICU mortality in those more than age 80 or above is nearly 22%, and overall hospital mortality is nearly 35%. And comparing medical and surgical mortality, the surgical mortality is higher. So the key anesthetic considerations in elderly critically surgical patients is those patients have reduced physiological reserve, across all organ systems. And so because usually those patients have associated underlying medical conditions, our blood pressure target has to be individualized. So we have to avoid both hypotension and hypertension. We have to also target multimodal analgesia, reducing the opioid burden. And those patients are also at high risk of delirium. So we have to minimize benzos and we have to promote early mobilization because those patients with age, they get more frail. We have to do the frailty assessment and we have to inform the goals with the team. And early involvement of geriatric and palliative care teams whenever appropriate is advised. The other patient group is those obese patients. So those obese patients have high risk of difficult airway and desaturation. So we have to be careful whenever positioning those patients. We have to use video laryngoscope and we have to pre-oxygenate them with high flow nasal cannula or the transnasal humidified air. And we have to prepare for difficult airway algorithm because of the difficult nature of their anatomic airway and the respiration because they have reduced functional residual capacity and high closing capacity. We should be pre-oxygenating them well and expect early desaturation. And we should also target lung protective ventilation. High PEEP is often required and risk of post-operative respiratory failure is also higher. Those patient groups have increased cardiac output demand with possible pulmonary hypertension. Obstructive sleep apnea is also common, so we should be careful with opioids in those patient groups. And positioning of those patients also might have an effect on hemodynamic. And coming to pharmacology, dosing, depending on the type of medication, we should use the ideal or the total body weight. And they also have altered volume of distribution, so we should keep in mind whenever administering medications. Prolonged emergency is possible, and we should target multimodal analgesia like any other patient group. The other is glycemic control. Hyperglycemia increases risk of surgical site infection and it impairs neutrophil function. So we have to keep tight but safe control is essential. So the recommended target in most critically ill surgical patients is between 140 and 180. But in some selected patients like cardiothoracic and high-risk patients, there are also some protocols that recommend targeting between 80 and 150 milligram per deciliter, have limited benefits with careful monitoring. So intraoperatively or in the critical care setting, they usually recommend insulin infusion, but monitoring has to be done hourly or more frequently, glucose checks during continuous insulin infusion until the patient is stable. And protocol must also include clear stopping and treatment algorithm for hypoglycemia. And we have to plan transition to subcutaneous regimens before the patient is discharged from the ICU. Perioperative pain management in the critically ill patient. Pain is assessment is challenging in intubated or sedated patients, but multimodal opioid sparing strategies improve outcomes. So among the validated assessment tools in critically ill surgical patients is one is the numerical rating scale, but this is done in conscious and communicating patients. The other is the behavioral pain scale or the critical care pain observation tool can be used to assess pain. The other is nutrition. So early appropriate nutritional support improves outcome. Interruptions to enteral nutrition are common and consequential. So whenever possible, interruptions should be minimized. So enteral nutrition is preferred according to the ERA's recommendation. Feeding should be started as early as possible, usually within the first 24 to 48 hours. if gut function allows, because enteral nutrition protects the gut barrier and maintains GI microbiome and lowers infection complication in relation to the parenteral nutrition. So the common reasons for interruption are during procedures, when patient have high residual or there is hemodynamic instability. So we have to reinitiate enteral feeding as early as possible. Coming to the parenteral nutrition, it is indicated when enteral nutrition is contraindicated or when it is insufficient. But parenteral nutrition can be delayed if the patient is well nourished from the outset until 7 to 10 days. But when patients happen to be severely malnourished, it should be started early. And when we start parenteral nutrition, we should monitor for refeeding syndrome, and it's administered through central access, especially when patients are on full parenteral nutrition. So we have to transition patients to enteral nutrition as soon as possible. The other is perioperative monitoring and goal-directed therapy. Modern monitoring combines clinical evaluation with technology to detect deterioration early and guide therapy. So the basic continuous monitors like EKGs, saturation, NIBP, end-tidal CO2 temperature, and urine output, arterial blood gas, serial measurements, lactate, and central venous pressure, and other advanced monitoring can be used based on the patient categories we face. So post-operative care and ICU transfer, the immediate priorities, one is we should keep monitoring and supporting the hemodynamic of those patients whenever transferring them either to PACU or to ICU. And ventilation should be lung protective if the patient is intubated. Temperature should be kept normal, normothermia, pain and sedation should be controlled. And we have to assess surgical sites and drains. During handover, we can use the structured communication tools like the SPAR or the IPAS, and full history of intraoperative event, current infusions, and any targets, pending investigations, and goal of care status should be also precisely communicated. So whenever monitoring patients, we have to avoid care gap during transfer, and same level of monitoring should be maintained during transportation, and we should anticipate deterioration during transportation, and we have to make ready emergency drugs. ICU team and bed should be confirmed before we leave the OR to transfer the patient. And the potential early complications after surgeries include bleeding, hematoma, respiratory failure, arrhythmia or acute coronary syndrome, delirium, stroke, or acute kidney injury. So the impact of delayed ICU admission, shortage of ICU beds is increasingly common, and boarding critically ill surgical patients in the PACU is associated with worse outcome. And evidence shows that prolonged waiting in the PACU more than 6 hours due to ICU bed shortage was independently associated with higher ICU mortality. So due to the early physiological deterioration without specialist critical care availability increases the risk of mortality. So the implication for our practice, we have to advocate for timely ICU bed allocation for high-risk post-op patients, maintain critical care level monitoring and staffing in the PACU boarding situations. We have to have clear escalation pathway and senior decision maker involvement. We have to document delays and outcomes for quality improvement and resource planning. And we also should consider pre-op discussion of post-op destination in high-risk patients. So the management of critically ill surgical patients should always be multidisciplinary. It should involve anesthesiologist or intensivist surgeon, critical care nurse, respiratory therapists, pharmacy, and other specialists, because all those disciplines contribute to the safe management of those critically ill patients. So key challenges and common pitfalls. Usually, such patients are recognized late, so failure to identify the deteriorating patient early on the ward or in the PACU, hypoxia and hypotension during emergency intubation remains the leading cause of morbidity. We also see communication gap, like incomplete handover between teams, leading to misinformation and care discontinuity, inadequate resuscitation, like proceeding to induction before restoring minimal perfusion and oxygenation, excessively uh, giving fluids crystalloid, resulting in tissue edema, longer ventilation, and organ dysfunction. So those are the key takeaways. We have to identify high-risk patients early and treat physiological deterioration aggressively before induction of anesthesia whenever possible. Airway management in the critically ill demands meticulous preparation, optimal pre-oxygenation, and hemodynamic support. Fluid vasopressor and ventilation must be individualized. We should not use like fixed recipe for all patients. And special patient groups require specific physiologic consideration and planning. Seamless multidisciplinary communication and timely ICU access are as important as the technique of anesthesia. And continuous reassessment, goal-directed therapy, and attention to pain, serum, sugar, and nutrition improves outcome. Those are the references I used. Thank you.
Thank you so much, Doctor. And thank you as well to the audience. So I'm sure some of you may have questions. Do feel free to post them in the chat, as there will be a dedicated session for that. So my name is Dr. Ian Sote. I'm a medical doctor from Nairobi, Kenya, and I'm also a committee member with the Operating Room Global. So for me, it's an honor to introduce our second speaker, who is Mr. Anas Jahangir, a lecturer in Operation Theatre Technology, a surgical technologist, an educator, a researcher, and a perioperative healthcare professional based in Pakistan. Mr. Jahangir holds a Master of Science in Operation Theatre Technology and has completed additional qualifications in healthcare management, supervision, leadership and management, basic healthcare, basic life support, advanced cardiac life support, and pediatric advanced life support. He currently serves as a lecturer at Foundation University, Islamabad, and is affiliated with the Berhe International Hospital Safari in Rawalpindi, where he contributes to perioperative practice, surgical technology, clinical training, and healthcare education. His professional experience spans university teaching, surgical technology, operating room management, academic coordination, curriculum development, clinical supervision, and perioperative workforce training. In addition to his clinical and academic work, Mr. Jahangir is actively engaged in research and scholarly activities with 21 peer-reviewed publications and experience serving as a peer reviewer for scientific journals. His key areas of interest include surgical simulation, robotics, advancements in surgical technology, surgical innovation, surgical oncology, and healthcare education. Through his work in academia, clinical practice, and research, he continues to promote excellence in perioperative care and the advancement of allied health professionals. Today, he will be speaking on the surgical technologist's role in perioperative care. So please join me in welcoming Mr. Anas Jahangir. Thank you.
Everyone, greetings of the day. Please confirm whether I'm audible.
Yes, you are. You are audible.
Okay. Just let me share my screen. Pardon for the delay. Anyone please confirm whether my screen is visible to all of you?
Yes, the screen is visible. You're good to go.
First of all, I would like to thank the Operating Room Global Network, the team, the leaders for giving me the opportunity to present here. Secondly, I would like to thank Mr. Sute for in-depth introduction. Okay. Myself, Anas Jahangir. I work as a lecturer at Foundation University, Islamabad, Pakistan, and I do also work as surgical technologist at Berhe International Hospital Safari in the evening. Okay. So let us start. I am supposed to start from the introduction and the biography, but Mr. Sute gave an in-depth introduction of mine. So I guess I should skip it. You all are aware of that. So let us directly jump to who are the surgical technologists. Surgical technologists are the basic specialized healthcare professional who do bachelor's, masters in surgical technology. Initially, the trend emerged from the two-year diploma program in Pakistan, abroad as well as surgical technician, which was later added on in the form of surgical technology bachelor program. So what does they do? They manage surgical instruments, maintain sterile field, prepare operation theater environment. Collaboratively, they work closely with the surgeons, nursing staff, anesthesia staff. Along with these services, surgical technologists provide managerial services to operating room suite, which involves specialized training, educated in surgical patient care, anatomy, aseptic technique, OR safety protocols. They are the core team members. Surgical technologists are responsible for instrumentation, sterile field integrity, and operation theater environment management. Okay. So, what does championing surgical standards mean to me? For me, clinical leadership means a lot. Secondly, the operating room global hub where we believe a collaborative network of surgical professionals that is dedicated for bridging the surgical education gap and sharing resources within low resource and low or middle income clinical settings worldwide. Okay, what is 2026 strategy? That is driving the vision to empower surgical technologies through the evidence-based practice, digital knowledge exchange, and advancement of global perioperative care. Moving forward, I would like to define the perioperative pillar. Strategically, perioperative pillar is very much important because surgical technologists ensure the safe and effective procedures through rigorous aseptic technique and equipment mastery. Okay, then three phases of care. Basically, we pronounce it perioperative care. All of you are aware, which involve preoperative, intraoperative assistance, and postoperative management. A surgical technologist is also involved and aligned with the operating room global and WCSTA 2026 standards to moderate surgical workflows worldwide. Okay, the phase one, that is preoperative foundation. The preoperative foundation involves making the theater ready before the start of the surgery, setting the stage for clinical success. Responsibilities include gathering specific surgical instrument, making it sure whether they are sterile or unsterile. Then, in the next step, creating the sterile environment and verifying all the necessary supplies before the first incision. Second phase is intraoperative phase. In intraoperative phase, a surgical technologist should be precise. It involves anticipation. Anticipation means a surgical technologist should be predicting whether a surgeon need which thing in his or her next step, and he should be handling instruments with clinical speed. The second most important thing is asepsis. Asepsis involves maintaining the sterile field throughout the entirety of the operation. There are various aseptic techniques given in Berhe and cones. The third phase is monitoring. He should be aware of vitals and instrument count for the safety. Similarly, the not just the instrument count, the surgical count even involves the count of the abdominal sponge, lap sponge, pelvic sponge, similarly gauze pieces or any other things that should be done before the closure of any cavity or the skin. In the third step, post-operative closure. This is not just the closure of the patient. After the patient leaves the operation theater, a technologist should be re-sterilizing the instruments, the operation theater. He is accountable for all the supplies and preparation of for the subsequent procedure with precision. I would like to add one more thing. After every 2021 cases or any positive hepatitis B or C case, or at the end of the day, the fumigation, carbolization protocols are also the part of post-operative. Okay, the standard AON 2026 that are gold standards worldwide, they have revised the 36 guidelines which are updated, in which the four I would like to discuss. The transmission precautions are updated, tissue management is updated, surgical energy safety is updated, and AON has also revised the anesthesia care, specifically in the form of systemic toxicity in local only anesthesia cases. Okay, what does the innovation mean for a surgical technologist? The modern theater. The modern theaters are also pronounced as modular theater, which involve robotic assisted surgery, AI-driven workflows, similarly AI integration with many workflows demands. Technologists now manage the complex hardware and hybrid operating room environment. A theater in the modular form is highly integrated, highly equipped, and highly like full of modern equipment and technology. What are the safety protocols which should be given by the surgical technologist? A surgical technologist, being a ST, he is also a safeguard for the patient. First of all, vital monitoring is very essential thing. Surgical technologist, when he is the part of anesthesia team or working along with anesthesia technologist, he should be assisting the anesthesia team in tracking physiological responses. Those responses might be against any drug for the anesthesia or the incision or the exploration inside the body. Then supply accountability is very much important thing that adheres with surgical count. Similarly, the supplies instrument must be available on spot, pre-operatively, intraoperative, and after the procedure ends, then those are closed. The soft skill a surgical technologist must have, those skills are mental and emotional resilience. What does that mean? Beyond the technical skill, the role requires effective communication, sound judgment under extreme pressure. Operation theater is like a daily exam for everyone, a real world, like a real lifetime exam, which examines you by giving extreme pressure, by giving sudden moments, and many more things. You should be able to maintain calm during surgical emergencies. If you lost nerve, you have lost the patient. Okay, the list of roles a surgical technologist must be able to perform, that are surgical assistants. These roles usually vary from country to country, but but in different forms the role remains the same. First of all, first of all is surgical assistance, then instrumentation. The third role is perioperative care.
I hope this thing.
Next one is operation theater management, including the management for CSSD, the Central Sterile Services Department, HR in the operation theater, like how much staff we have in each shift, and whether that staff is enough for surgical list. And inventory management is also a role of surgical technologist. A technologist must be developing the standard of practices aligned with relevant accreditation body like Punjab Healthcare Commission in Pakistan. Similarly, many federal bodies and at international level, many accreditation bodies like JCI, ISO. Policy development is also a role of surgical technologist. The role I usually say that we lack somewhere, unfortunately, that is research and development. We must be very much efficient in research and development. And the last, not the least, is leadership and mentorship. We should be providing leadership and mentorship to our junior staff. Okay, credentialing the global excellence that involves accredited education. Program must follow CAAHEP or ABHES curriculum standards for 2026. Certification programs involve CST certification, NBSTSA exam, that is a benchmark for professional entry. Similarly, various countries have their own exams as well. Lifelong learning. We should be committed to lifelong learning. Requirement for 30 continuing education credits every 2 years to maintain the mastery. Last but not the least, what is the future horizon for a surgical technologist? Surgical technologists must be a part of interdisciplinary team that will explore enhanced recovery after surgery, cardiovascular critical care at upcoming 2026 STS conference. More future pathways for a surgical technologist involve simulation-based technologies, robotics, minimal invasion. I have highlighted a bullet named PhD. I would like to request all the surgical technologists globally, the technologists as well as the associations or communities, that the surgical technologists with master education must be trying for a PhD, because we have very less or even no person with PhD in our field. If anyone gets the doctorate, he will be able to give us the extreme leadership capabilities, and he will be delivering very good SOPs, policy management, research and innovation. That's it. Okay, final thoughts of mine are commitment to clinical integrity. As surgical landscape transforms, the surgical technologists remain the guardian of sterile field and the patient's silent advocate. I am open for questions and discussions. Thank you. Over to Mr. Sute.
Can you hear me?
Yes, I can.
All right. Thank you very much. I think the next phase now is question and answers for both presenters. And at the moment, there's no question. So there are two questions for the first presenter. So I'll just go straight to Dr. Gebru. Right. So the first question is from a nurse in Nigeria. She writes, "Thanks for the presentation. It was beautiful. I lost of poor pre-assessment from anesthesia. What would you advise going forward to prevent this?" Dr. Gebru, please.
Okay, thank you. So, thank you for the question from Jessica. I think the question is, she lost a patient as a result of pre-assessment from anesthesia team. What do you think I can do as a surgical practice administrator to encourage all the team to ensure meticulous assessment of critically ill patients, both by the surgeon and the anesthesiologist? So yeah, it might, as to the rules, who do what and at what time, it might differ where in the world we practice, but generally we can agree that everyone should be contributing to the assessment of the patient. So primarily the surgeon and the anesthesia provider should make sure that the patient is evaluated and uh, resuscitated before taken to the operation theater. So we should make sure that the patient will be able to tolerate the anesthesia medications we give him in the operation theater. So in order to be able to tolerate those anesthesia medications, as far as time allows us, we have to do the at least the quick assessment and address those areas that need intervention, like the circulation, airway, the breathing, in the ABC of life manner. But in the meantime, every other team member can help in optimization of these patients. Did I answer your question,
So,
Jessica?
your response making me to ask.
Okay.
I work in the operating theater, so I understand vividly what you're saying. However, if I get maybe the import, in what way do you think this specific important role of the anesthesia team can be structured in such a way that you are sure of what you're doing? You are sure you're not missing out anything. For example, the use of a checklist or any other format to missing anything else. I don't know what you think about that. Thank you.
Yeah, so depending on the patient group we get in the operation theater, if in the place where we practice, if we have a checklist, that would be an important tool in order to not to miss what we do, and it will help us guide to do what we do structurally. But whenever possible, every team member should be involved and tasks should be allocated in order to avoid communication confusion and to efficiently use the time, that minimum time we have before taking the patient to the theater. So we need to have a leader in that perioperative team. So we have to have a checklist whenever possible. Yeah.
All right. Thank you very much. It does appear there are no questions. The next question is coming from me.
Okay.
I practice in Nigeria, and yes, I asked of your presentation. I was really impressed when you emphasized the all-inclusive care, which is a multidisciplinary care approach. For me, it's beautiful, and I think that's the way to go. However, in some settings, I'll say my country, for example, there's this saying that a job description, which is supposed to marshal out what you're supposed to do, it's in itself making teamwork not possible, in the sense that team A cooperating with team B as not my job. It's a problem, and I'm not sure if it happens where you come from, and is your take and advice to where this happens. Thank you very much.
Thank you for the second question. I think this is the challenge, I can say, even in Ethiopia where I practice, it's not always seamless. I mean, there is always a gap, and you don't sometimes know how to communicate with the team, and with also the job description, which team is going to do what. And when you have different type of patients, it even get more difficult. So, like you mentioned previously, we have to develop our uh, local maybe regulation or any from our practice. We have to have our uh, practice protocols. Otherwise, that's similar where I practice now. There is difficulty in getting every team to get to communicate clearly, to have discrete, yes, job description. It's a challenge even where I practice, but I think we can develop protocols and solve those issues with time.
Thank you very much. While you were answering, there was another question for you, but I'm not sure because they didn't write the name. The question simply says, how can you manage pain preoperatively from shock patients?
Yeah, so for 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 shock patients, it depends where the source of sepsis or where the source of infection is. But wherever the source of the infection, the principle when managing pain in infection patients, even when they have septic shock, it should be that we have to use as much as possible opioid free and multimodal, more going to the regional techniques in order to minimize the hemodynamic uh, side effects of the medications or the regional technique we use. So we might not say like drug A or drug B specifically for any patient, but it depends on what type of surgical incision, which area those patients have septic shock from. So we have to focus to the principle that we have to try to avoid drugs that affect the hemodynamic of the patient, because those patients already have hypotension from the shock state of sepsis. So
Okay.
thank
All
you.
right. Thank you very much. I think the next question is for Anas Jahangir now. Mr. Anas, your question: the role of surgical technology should evolve from an instrument-focused role towards a more active clinical role in perioperative patient safety. What competencies would be required?
And thank you, Mohammed
I
Muazzam, for
have
the
I have
question.
my own concern.
Okay.
Yes.
Thank you very much, Mohammed Muazzam, for the question. And this is, I guess, the question of every evolving surgical technologist worldwide. So first of all, if we say we should neglect the instrument role for a surgical technologist, that would be unfair, because without instrument focused role, surgical technologist is not entirely a surgical technologist. He must know about the instrument handling, how to handle the instruments, how instruments are being handled if, by junior ones or by CSSD staff, but he must be aware. But if we focus toward safety role, then what competencies would be needed? There are several master programs focusing on patient safety in terms of, we will have to define patient safety first. What does patient safety means? It is not just a word. It involves safety from the infection in a broader way toward any situational emergency, anything like that. So what competencies would be needed? You will need to know situation based awareness. You will have to do anything like Six Sigma Green Belt managerial diploma or certification, or safety programs given by ISO as well as USHA. You will need to provide to get certification from those things. Thank you.
Okay. This is from me now. I would need a very, personal opinion. Some countries do not have, while a few, no, few others have.
I guess you're having
So
any net
there is,
issue. Can
yes.
you please
I'm
repeat
not,
this line?
hello,
You're not
can you hear
well.
me?
Yes, yes.
Okay, I said, summary of is no has theater surgical technologists. Some has perioperative nurses, while in the such centers you have theater technologists. And if you look at the roles you specified in theater technologists, it includes supplies, worry about instruments, sterile fields, and all these are core parts of perioperative nursing. I'm not sure how they meet or how they work together or how they should work together to ensure that there is safety in the operating room. Thank you.
Okay. Well, basically, the perioperative nurse or the surgical technologist, there is no like a broader difference between these two terms or professionals. In few countries, the person bearing operation theater technology degree, he is referred as perioperative nurse. In some countries, the person with this degree is pronounced as operation theater or surgical technologist. So basically, they work collaboratively in the sterile field. Usually, perioperative nurse is at instrument trolley. The technologist or first assistants gets the instrument from the trolley via a perioperative nurse. But the role for a surgical technologist is even beyond the instrumentation. That is documentation, managerial role, shift
Okay.
management. So these two, in specifically in middle or low income countries, specifically the tertiary care private hospital, they usually do not hire both ones. They either hire a perioperative nurse or they hire a surgical technologist, which has to do everything like this. Okay. So if they both are hired or working in the same environment, they have different roles. Perioperative nurse has scrub role in a broader term. He or she has other roles as well. But a surgical technologist, he has the JD beyond the instrumentation as well, in the form of shift maintenance, in the form of documentation, policy, record maintenance, and such things. But they should be working collaboratively.
Thank you, everyone. I want to thank both of our speakers and thank you for moderating and joining us today. Unfortunately, we're out of time, so we will have to end our Q&A segment here. I would now like to invite Mr. Raza Khan to deliver the closing remarks. Thanks again.
Okay, thank you. On behalf of the operating room global, I would like sincerely thank to our two distinguished speaker, Dr. Fekrey and Mr. Anas Jahangir, for their valuable presentation and for sharing their insights, knowledge, and experience and practice. I would like also participants joining from different countries, institutions, professional backgrounds, and time zone. Thank you for your active participation and commitment for continuing professional learning. So we recognize that despite the busy clinical schedules and professional commitments, and the participants joining us from the globe, we greatly appreciate your time and commitment. Please continue to stay connected with us in upcoming webinars, educational programs, training opportunities, and research activities. Before we close, a brief reminder regarding the certification. The evaluation of certification and form will be open immediately after this session and will remain open and available for 24 hours only. So completing of the
evaluation program is mandatory to get certificate, and for the certificate, your core membership ID will be required. And the eligible candidate, the eligible certificates will be dispersed within 5 to 7 working days. So once again, thank you, Dr. Fekrey, Mr. Anas Jahangir, the operating group global team, the participants. Please, once again, warm welcome and good evening, good night, and according to your time zone. Thank you. We look forward to welcoming you again in future for the future sessions and other activities. Thank you.